Hello, folks. I'm Dr. Kenneth Candido, Chief of the Division of Pain Medicine at Advocate Illinois Masonic Medical Center in Chicago and Chairman of the Pain Medicine Fellowship, as well as Professor of Clinical Surgery and Clinical Anesthesiology at the University of Illinois College of Medicine in Chicago. This morning, I'm privileged to present at the Society for Pain Practice Management, Prescribing Opioids and Controlled Substances, Best Practices 2022, Know the Guidelines to Prescribe Appropriately. I have no disclosures. I've got nothing to document in terms of any industry funding or any conflicts of interest related to this topic. The rationale for prescribing and why we need to have guidelines and follow guidelines really comes down to the fact that we've been in the midst of an opioid epidemic now in this country for many decades, with an explosion, however, of deaths seen in the last 1 year. From April of 2020 until April of 2021, we saw a 28.5% increase in deaths, overdose deaths related to controlled substances. And we as clinicians have a duty to identify high-risk patients and take all appropriate precautions to legitimately use opioids for chronic non-malignant pain when indicated, sparingly, judiciously, and taking into consideration alternative and competing strategies for managing pain. So the guidelines are fallible from the Center for Disease Control in Atlanta, Georgia, that came out in 2016. They were intended for primary care physicians, but we, of course, got dragged into the net of oversight and supervision by regulatory agencies, and it's our duty to protect ourselves while simultaneously protecting our practices and our patients. So prescription drugs were formerly driving the epidemic, and it was considered dogma that physicians and big pharma were largely at the forefront of feeding the opioid frenzy and the opioid epidemic. But we know in retrospect, in hindsight, that it's really not prescription writing. It's the synthetic opioids and fentanyl that has been manufactured in China in a powdered form that comes across our borders from Mexico and China, which is reconstituted into pill form and pill mills in places like Los Angeles and in Arizona and Texas, and is then distributed in the streets of this country, killing our children and killing our patients and destroying lives in our practices and those of our patients as well. So synthetic fentanyl is the number one offender that we have to be apprised of. And how do we know that this is actually occurring? Well, the CDC actually admitted it in 2018. I'll show you the graphic on that, which was a little editorial published in a pharmacology journal a few years back in 2018. In 2021, we found that we had a 28.5% increase in overdose deaths in this country. A staggering 100,306 Americans were killed by overdoses of all drugs, of all chemicals, opioids, cocaine, benzodiazepines, street drugs, prescription drugs. People were dying at an exaggerated rate, with Vermont, interestingly enough, being the state with the highest incidence of a 70% increase in overdose deaths. So I don't know about the great Senator Bernie Sanders. Before he runs for president, he better clean up his state, because they're having a mess up there in Vermont. And so if you take a look here, Vermont, 70% rise. And then, of course, the usual suspects, West Virginia and Kentucky, for example, also leading the pack at 62 and 54%. Those are frequent repeat offenders, along with the state of Ohio, the state of Florida, for example. New York is now represented with a 20% increase in that 1 year period from April of 2020 to April of 2021. And that 28.5% increase compares to the death rate in the previous year. From April 2019 to April of 2020, where 78,056 individuals lost their lives to overdose. And this represents, of course, the so-called Bible Belt, where it all started: Ohio, Kentucky, Tennessee, West Virginia, and Florida. But now we see Vermont leading the pack with a 70% increase in overdose deaths from all drugs: prescription drugs, non-prescription drugs, fentanyl, morphine, heroin, cocaine, benzodiazepines, all, and amphetamines, of course, killing our countrymen and killing our patients too, because our patients sometimes get dragged into this net by using their legitimately prescribed medication and trading it in. Tom Petty had prescription opioids, traded them in for fentanyl and died. Prince, the musician, had prescription opiates for his chronic orthopedic non-malignant condition, traded them in for fentanyl, and died of fentanyl toxicity and fentanyl overdose. Fentanyl is becoming more accessible to kids on social media. And you have to be aware of this if you have children. I've got a 15-year-old, a freshman in high school. I asked her what she knew about fentanyl. She was remarkably cognizant of the fact that this is a narcotic that kills people. Now, she's not a pharmacist. She's not a physician. She hasn't had medical training, but she knew, she heard of this drug. She knew at least remotely of its being accessible in the school system. So we had that daddy-daughter talk that many of you have had, and you have to have this similar type of talk with your patients as well. The drug's been found in vape pens in high school and mixed with marijuana. Tragic conditions happened this past weekend in Connecticut. So here's an article published in November of 2021 in the New York Post about Connecticut officials warning parents and warning school districts that people were mixing marijuana with fentanyl and people were smoking it up and having seizures and going into comas and dying. And this, January 14th of 2022, 3 school chums, young kids, 13 years old, got some fentanyl, got their hands on fentanyl, brought it into the school system. 2 kids didn't feel good. They fell down, but they were okay. 1 kid collapsed on the floor of the school. The teacher provided mouth-to-mouth CPR resuscitation. The kid died on January 16th of this year, a mere few days ago. This is not an isolated situation, ladies and gentlemen, but we as physicians and prescribers of opioids need to identify substance use disorder and protect our patients, our families, our practices, and ourselves. And then December 17th, 2021, published article, authorities seize a record 1.7 million fentanyl pills in Arizona. Well, that's where they're reconstituted from the fentanyl that's made and manufactured in China in a powder form. This is what it looks like here. 360 pounds of fentanyl pills, 10 kilos or 22 pounds of powdered fentanyl, 1 pound of methamphetamine from the Sinaloa cartel in Mexico. It's made in China. It's brought to this country and through Canada and Mexico, reconstituted in pill mills in Los Angeles and Arizona, Texas, Florida, and elsewhere. And our people are dying from it. So you're a prescriber. Obviously, you don't really know what this has to do with you. Well, it has everything to do with you because some of your patients, your legitimate pain patients for whom you in good faith undertook to prescribe opioids as Schedule II chemicals, are trading them in for illicit drugs because they get higher, they fly faster, they go farther with fentanyl than they do with your buprenorphine or your oxycodone or your hydromorphone, hydrocodone, fentanyl. Fentanyl is what's killing people, ladies and gentlemen, primarily. So the CDC, in their infinite wisdom, came out in 2016 with these guidelines, and they were intended for primary care physicians first and foremost who treat chronic pain. Pain defined as that extending for 90 days or greater. It's an arbitrary and capricious designation. And the Fed said, well, you should try to avoid more than 90 morphine equivalents per day or milligram equivalents per day of opiate. Except under some exceptions, because we know that PCPs have the management, they're the gatekeepers. They see these patients first and foremost, and they're not prepared for what awaits them. They're not prepared to manage the side effects, nausea, vomiting, itching, urinary retention, constipation, respiratory depression, by and large, associated with opiates. They don't know as much about the confluence of substance use disorder with chronic pain. 15 to 25% of patients with chronic pain who have that concomitant substance use disorder. And so these guidelines came out and they were subsequently bastardized because they were generalized to any physician, even those of us with great training, SPPM members and so forth, who understand a bit about substance use disorder and chronic pain. And the guidelines said we should start with the lowest effective dose. Well, that's intuitive and inferential, isn't it, ladies and gentlemen? We know you don't want to start off a patient with 240 oxycodone tablets per day. And in fact, I avoid oxycodone because it's as lethal and as addicting as heroin. So I can count on one finger the number of patients in my practice who are prescribed this. And that's from new patients, I will never initiate the use of oxycodone. And it has nothing to do with the Sackler family, Purdue Pharma, and my general disgust with that whole concept of how they fueled the opioid epidemic. I just think that the drug really should be used for chronic malignancy-related pain. Nevertheless, the feds came up with this, avoiding increasing dosages to greater than 90 morphine milligram equivalents when possible, or carefully justifying the requirement to titrate upwards. So how did we get to 90? Well, studies were conducted in overdose patients, including those who died, and it was found that the use of 100 morphine milligram equivalents per day was associated with a 9-fold increase in the overdose risk. So the feds took 100 and said, okay, let's reduce that by 10% to make it even safer for patients. And that's where they came up. It's not totally an arbitrary number, is it, ladies and gentlemen? They also found that there were higher risks with 200 milligram morphine equivalent per day, which was a 3-fold increase in overdose above this 9-fold increase already stated. So a 27-fold increase in the likelihood of overdose and death. And those with substance use disorder, the health risks were very high when we exceeded this 100 morphine milligram equivalents per day compared to lesser morphine milligram equivalents per day. So there is data to substantiate this number. Sanford Silverman recently retired from the great state of Florida. A good friend of mine, he and Peter Stath wrote a great book that I'm going to discuss with you at the end of this little talk in the next 60 minutes. It's a book that you ought to buy and keep on your shelf and study and learn from. It will protect you. It will protect your patients from undue duress and oversight by regulatory agencies, as well as the likelihood of injuring or harming your patients. And what Sandy said was that since the publication of these guidelines, many physicians have altered their practice regarding the prescribing of opioids. And we'll show you what the statistics are in that regard as well. It was created for primary care physicians, psychiatrists, family medicine doctors, internal medicine doctors. However, insurance companies, regulatory agencies, and state legislatures and oversight people have bastardized this and extrapolated to all physicians prescribing opioids. And that was not the intent, ladies and gentlemen. And so maybe we need what our procedure-specific guidelines rather than a blanket 90 morphine milligram equivalent statement across the board for all practitioners. And some people have tried to legitimize this, including our orthopedic surgery colleagues and our spine surgery colleagues. And this is a nice paper published 2 years ago in the Journal of Bone and Joint Surgery. They looked at reducing prescription writing to orthopedic patients who came in for surgery, joint replacement, knees and hips and elbows and shoulders, reconstruction, ACL, rotator cuff tear repairs, ankle surgery. And they found that they reduced the prescription writing following the guidelines by 38%. And that's fantastic because the orthopods who are not generally leaders, they're followers when it comes to pain management. They reduced the opioid prescribing to their patients by 38%. What they did not find, however, was that a 30-day period or after 1 month, still the same number of patients who sought a refill before the guidelines were implemented still came back for refills. So at initiation, they were able to get 90 or less. That was a good thing. They reduced opioid consumption by 38%. At the 1 month period, however, there was no alteration in patients' behavior. What about our spine surgery colleagues? Same thing. They reduced for cervical spine, thoracic spine, lumbar spine. They reduced opioid prescription dispensation 25% in the first 30 days. At 30 days, those patients came back in droves, the same number, seeking a refill on opioids. So what's happening? Well, the surgeons are seeming to get it. They're giving less patients opioids, 38% for orthopedic surgery, 25% for spine surgery. But at 30 days, something is happening. Those patients who are predisposed to get opioids are going to come back demanding opioids for this chronic pain. The great state of Florida led the charge with legislation to try to regulate physicians and tried to conform physicians' behavior so that patients were not unduly harmed. And how did it work? Well, when Rick Scott was governor in 2018, he came up with 6 postulates that every physician must undergo mandatory physician education before they dispense Schedule II chemicals, drugs like oxycodone, hydrocodone, hydromorphone, fentanyl, for example, for legitimate medical purposes. They had to have 2 hours of education every 2 years to be able to renew their Florida medical license if they had a DEA license. Mandatory review of prescription drug monitoring program. I sit on the prescription drug monitoring program for the great state of Illinois, and I can tell you a lot of physicians are not compliant. They're doing things way outside the box, and they are red flagged and they are scrutinized. There should be a limitation on prescribing controlled substances. There has to be cognizance and understanding and education and implementation of opioid antagonism. So drugs like naloxone or Narcan or naltrexone have to be understood, especially in the acute pain situation. There is a mandatory application if someone is seeking what's called a certificate of exemption, meaning you believe your pain practice is exempt from these regulations. It's very rigorous, very strenuous, and very few practices actually qualified for a certificate of exemption, which must be renewed, by the way, completing an arduous process every 2 years. And of course, the standards of practice for treatment of acute pain were implemented by the state of Florida, but also by other states as well. So the state of Florida, with their 21 USC S.822 law, stated you must complete a board-approved continuing education course on prescribing controlled substances as part of the biennial license renewal if you hold a DEA administration certificate. And you have to complete a 2-hour continuing education course each and every time you renew your Florida license. There were 5 medical conditions, of course, which did not qualify for suitability for restriction of opioid prescribing under these new laws. And they included, obviously, cancer pain, pain due to terminal illness, some type of terminal illness not related to malignancy, ALS, for example, or some other chronic neurological condition, provision of relief of symptoms related to an incurable progressive illness or injury, palliative care, or serious traumatic injuries. The state also mandated that if you're writing Schedule II controlled substances for your patients, that you must interact physically with your patient, or now remotely by the use of telehealth, for example, since the pandemic hit at almost the same time, every 3 months or less. So you have to see your patients at least every 90 days and document the response to treatment. So if John Smith comes in and he gets his 240 oxycodone tablets, and I don't recommend that, today in January, you must document what the response to that treatment has been, as well as whether or not there have been any side effects attendant to the use of opioids, for example, nausea, vomiting, itching, urinary retention, constipation, respiratory depression, or difficulties. You must document the effects of your treatment. And of course, for acute pain, you are limited to a 3-day supply of medication with certain exemptions, meaning that you could petition the pharmacies for up to 7 days under certain circumstances. Now, the prescription drug monitoring database should be queried each and every time for each and every one of your patients who is seeking a refill of their medication. So that includes initiation. You go and look whether John Smith is getting prescription drugs from his dentist, what types, what quantities, when they were dispensed, as well as any aberrant drug-seeking behavior. It's your duty to utilize the prescription drug monitoring program, which is found now in almost all 50 states. And you don't have to do it yourself. I designate one of my nurse practitioners to do it, but it has to be somebody who's been trained, who's reliable, who understands conceptually what to do. For acute pain, you can provide a 3-day prescription or a 7-day prescription under certain exemptions. That is, where the patient has a medical necessity, you can seek an acute pain exemption. We'll talk about that. We'll talk about injury severity scale scoring in just a few moments. You have to document in your prescription that there's lack of an alternative treatment option for this patient, for this 7-day emergency supply of medications, under what circumstances that this is the only remedy for the patient's ailment at the time. Now, when you do designate the person as having a traumatic injury and requiring a certain 7-day prescription, you must also prescribe an opioid antagonist, typically Narcan, for your patient. You must understand Narcan. You must learn to understand the risks, the benefits, and the alternatives to Narcan use. But it's a state law, at least in Florida, that for traumatic injury with an injury severity score of 9 or above, remember the scoring goes from 1 to 75. If that patient has a 9 or above and you're giving opioids, you must prescribe an opioid antagonist with instructions for use to your patient. So what is the injury severity score? It's an international scoring system, internationally recognized for how we rate acute pain due to some type of traumatic injury, gunshot wound, school bus accident, industrial accident. We rate the areas of the body which have been injured. We start at the head or neck, face, chest, abdomen, pelvis, extremities, or external, and we rate these areas based upon the severity of their pain. We take the square of those injuries and we designate a score from 1 to 75. The higher the number, the greater the severity, for example. So let's take an example. This is just a cartoon. This is just a hypothetical patient who's had a multi-system traumatic injury to their body. They have a cerebral contusion, internal carotid artery transection. Their highest adjusted injury score is a 4. We take the square of 4. 4 times 4 is 16. That gives us the number here. Then they were also injured here with a retroperitoneal hematoma. That's their second most significant or severe injury. We take that number of severity, 2, we square it up. 2 times 2 is 4. We derive a number. And then they've got a fractured femur. That's their third most severely injured body part. That derives an injury score adjusted to 3. The square of 3 is 3 times 3 is 9. And now we have 16 plus 9, which is 25. And add 4 to that, that's 29. That's our injury severity score. It's in the mid-range, pretty significant, pretty severe. The Board of Medicine adopted standards as well. And physicians had an inducement to be compliant. And that inducement was that if they weren't compliant, that could lead to disciplinary action against the physician. Does that happen? Yes, it does happen. They had to understand what constitutes acute pain, what constitutes chronic pain. Chronic non-malignant pain is pain unrelated to cancer. We talked about this, persisting beyond the usual course of healing or the disease or injury that caused it, or for more than 90 days, that's 3 months after surgery. Acute pain, however, is a normal, predicted, physiological, time-limited response to an adverse event, chemical, thermal, or mechanical, associated possibly with surgery or trauma or acute illness. The term does not include pain related to malignancy or a terminal condition or palliative care or a traumatic injury with an injury score on severity of 9 or greater. Know these terms, know what the consequences are of treating acute pain versus treating chronic pain. Now, there was a mandatory application. I mentioned this earlier for a certificate of exemption. Florida and other states have certificates of exemption. They're very hard to derive and come by. The criteria are very stringent and rigorous. The application process is arduous, and it has to be renewed each and every 2 years if you qualify in the first place, which is unlikely for most of us in private or academic practices. What happens to individuals who stray? There are severe consequences if you stray outside the prescribing guidelines of your state. And you need to know what the prescribing guidelines are within your state. You need to query your state government and your state medical boards to determine what the prescribing guidelines are for Schedule 2 and Schedule 3 agents. We don't talk about Schedule 1 heroin because we're not using that. It has no legitimate medical purposes. Marijuana, considered a Schedule 1 drug. PCP, considered a Schedule 1 drug. We don't prescribe them by and large to our patients. So what are the risk factors for who's going to get prosecuted for stepping over the lines? This is a nice paper published in Pain Physician in the year 2020, showing that our specialty, pain medicine, has the highest percentage of in-specialty action. That's not a good thing, is it? Because physicians are being targeted as being culpable and culprits in the etiology and perpetuation of the opioid crisis or epidemic. So if you're an osteopathic physician, unfortunately, you're a little bit higher risk than an allopathic physician for being prosecuted for discretions related to opioid prescribing. If you're male compared to female, you're at a higher risk of being prosecuted for opioid indiscretions in prescribing. If you're in private practice versus academic practice, you're at a higher risk for being prosecuted. If you're not board certified, you're at a higher risk of being prosecuted. If you're in possession of narcotics with intent to distribute, well, that's a big time felony. You're going to go to jail for that. You're going to pay a hefty fine. And that's one of those situations where you better just do a mea culpa, plead out, and see what can happen to you if you get caught doing that. Of course, international medical graduates appear to be targeted or prosecuted a little bit higher than American trained physicians, although this did not reach a statistical significance. So have the legislations and guideline worked from the CDC from 2016? Yes and no. We know that we're prescribing less medication now than ever before. And if you look at the statistics that will be borne out, here's a study from the Institute for Human Data, science study. It showed a decline of 12% in the year 2017 from 2016. In general, there were 23.3 billion fewer morphine milligram equivalents dispensed to patients in that 1 year. That's a huge number. And the number is consistently on the decline even since 2017. So that translates to a 10 or 16% reduction, 16% reduction if we're looking at patients who were receiving greater than 90 morphine milligram equivalents per day. That number has declined precipitously, which led the chair of the AMA opioid task force, Dr. Patrice Harris, to opine that there's been a 22% decrease in opioid prescriptions between 2013 and 2017, reflecting the fact that the guidelines have rung true amongst not just primary care physicians, but all physicians who utilize Schedule II controlled substances. Now, interestingly, a very softly and unpublicized retraction, if you will, was published in the American Journal of Public Health on March 21st of 2018. We're in the Centers for Disease Control in Atlanta, Georgia, understood that they over-exaggerated or inflated overdose deaths due to prescription writing. Now, why did that happen? Well, if John Smith comes into the emergency department and he's in a fulminant overdose from opioids, and we know that because of his pupillary size, because of his lungs being filled with fluid and so forth, and he meets all the criteria, and he has a positive blood or urine test for opiates. And then the physician in the emergency department queries the prescription drug monitoring program and says, oh, John Smith was getting opioids from his family medicine doctor. So we're gonna label this much the way the government has labeled COVID deaths, right? Somebody could die from an MI, and if they just happen to have superimposed COVID, it's a COVID death until proved otherwise. Well, the CDC did the same thing with opiates. They failed to recognize the huge contribution of synthetic fentanyl, and many of the patients who just happened to have prescription opioids were really dying of fentanyl. Tom Petty, the great rock and roller who had a prescription, legitimate prescription for a medical condition for opiates, died of fentanyl overdose. Prince, the great musician who had a legitimate prescription for orthopedic medical conditions, died of a fentanyl overdose. And so if you look at them, however, at the time of their death, they were calculated as being due to prescription narcotics. They were not due to prescription narcotics. So the CDC had to backtrack softly and admit that they made a mistake, that they overcalculated primarily from emergency room admissions, deaths due to prescription narcotics, which were really due to fentanyl. Now, the economic burden of opioid overdose deaths is catastrophically enormous. In 2017, it was over $1.02 trillion. That's the economic cost of this. However, I just showed you data earlier on during this presentation, which indicated that the numbers have gone up 28.5%. So if you take that $1.02 trillion, it's probably closer now to $1.7 trillion per year related to overdose deaths in this country from all chemicals, opioids included. Trends in urine drug monitoring, even knowing this. Here's a paper in Pain Physician from early last year. Only 50% of the people chronically consuming narcotics are ever getting drug tested. We've got to do better. But how do we do better and balance that with the exorbitant cost of urine drug monitoring? Because we know that these urine drug monitoring companies are gouging the insurance companies. It costs about $30. Take a little specimen of urine and run it through your mass spec machine, and they're charging the insurance companies $1,000 and $1,200 and $1,500. So that adds to the economic burden of the opioid epidemic. But the governments and regulatory agencies are actually cutting back. There's been about a 32% decrease in reimbursement for urine drug monitoring to physicians and to the laboratories, independent labs, which are charging exorbitant fees and are really taking unfair advantage of the opioid epidemic, in my opinion. Now, in addition to the health consequences, well-known health consequences of opioid consumption, including the side effects profile, nausea, vomiting, itching, urinary retention, constipation, respiratory depression, attendant to the legitimate use of opioids. We also understand that opioids can reduce testosterone production. It can also impair immune function. And now there's data suggesting that it accelerates arthritic conditions of the extremities and the spine. So opiates and opioids are drugs which are not devoid of serious side effects and consequences, not just related to overdose, but related to their prescription writing on a routine basis, initiation of osteoarthritis and perpetuation. Here's a paper that I'm going to encourage all of you in this audience at SPPM to download and read. It's a free download on PubMed through Science Direct. You can get this article, Pharmacology Guidelines, published 2 years ago in 2020, a German group. It's their second iteration of looking at whether opioids actually work for chronic non-malignant conditions. This was led by Frank Petsky and Associates, who looked at all the data, all the literature, and said, do opiates work for up to 3 months? Do they work for up to 6 months? Do they work for longer than that? What conditions does literature support the use of opioids? You need to know this. You should print this table one and put it in your office in your pain practice and study it when you get new referrals, or when you have legacy patients or historical patients making a determination as to their suitability for ongoing use of opioids. So the level of evidence is 1A for chronic low back pain, osteoarthritis pain, painful diabetic peripheral neuropathy, and postherpetic neuralgia in the short term. 1A evidence for up to 3 months. But the evidence rapidly declines after that. So we know that you don't want to perpetuate and you don't want to use opioids ad infinitum for patients with chronic non-malignant pain. And here's the reason why: they don't work past a certain point in time. So you need to study this data. These are the 4 conditions for which there is level 1A evidence. However, the quality of evidence is very variable. And in many cases, it's pretty low. But nevertheless, there is evidence for up to 3 months. How about the other conditions? And I would throw fibromyalgia into this, even though it wasn't studied. Phantom limb pain, chronic pain after spinal cord injury, not good evidence. Radicular pain, not good evidence. Painful non-diabetic polyneuropathy, not good evidence. Chronic pain and rheumatoid arthritis, no. Restless leg syndrome, no. Parkinson's disease. So these evidence is 1B. Quality of evidence and the strengths of recommendations are pretty weak. You need to study this, ladies and gentlemen. You need to understand, so that if you get somebody who is critiquing your use of medications for chronic non-malignant pain, you can demonstrate a rationale or justification for making that decision. Now, don't be treating patients who are chemically coping. Don't be a pain doctor, an SPPM member, or a member of your other societies who's using opioids for managing anxiety, depression, mood disorders, et cetera. And so you need to know some definitions. Chemical coping, that's behavior that bears a resemblance to addiction because the pill taking is inappropriately used to manage stress. Don't manage patient stress with opioids, or for sleep disturbances, or for anxiety and depression. How do you determine who's at risk then? How do you know? You're a pain physician, you get a referral for somebody, and for the first time you see that patient, you need to do opioid risk assessment, which is a self-administered questionnaire. The patient can do it in their waiting area. Or the screener and opioid assessment for patients with pain, SOAP, SOAPP. Again, I like these patient-driven metrics because it doesn't detract from your ability to see patients who are already in your system, in your office. You don't have to dedicate a nurse practitioner or a medical student, resident, or fellow to go run out and query these patients or navigate them through these questionnaires. And they're pretty straightforward. ORT is simple. Just a couple of metrics here. Are you male? Are you female? Personal history, family history of substance abuse. Any consequences? Have you been a victim of sexual abuse during adolescence? Obviously, at a much higher risk for females than for males. How does that influence the patient? Well, it's a red flag that predisposes that person to a higher likelihood of substance use disorder. Be careful if they're at a high or moderate risk about utilizing or initiating opioids in that patient. Actually rate this, go through this, screen this, look at this screening tool, study this screening tool, administer it to all of your patients before the initiation of opioids. If they're at high or moderate risk, send them for a psychological assessment, evaluation, and support. These people are suffering. They need support. They need empathy, but they don't need opioids. Empathy and opioids are not synonymous one with the other. The SOAP test, also a patient-administered, self-administered test. They can do this in their waiting room. It can be completed as part of the interview if you feel the need to handhold with the patient or supervise the patient, but this can be done independently of your input. What about the molecule? We know certain drugs, oxycodone, OxyContin, bad drugs, highly addictive as alprazolam, as addictive as heroin, not good for initiation. And if you could avoid perpetuating that, that would be in your best interest. They are red flag drugs, in my opinion. Buprenorphine, a good drug, has been around for 40 years. We studied it, myself and Professor Alan Whitty, as an additive to local anesthetics for prolonging brachial plexus block and prolonging sciatic nerve block. It's a phenomenal drug, not devoid of side effects, by the way, but it's an antagonist at the kappa receptor. It's a partial mu agonist, but it binds very strongly to the mu receptor. If you take a series or a group of recovering heroin addicts and you put them in a room and they've been abstinent for many years and you expose them to tramadol and buprenorphine and oxycodone. They're going to love oxycodone because it resembles heroin at the brain, the pleasure center of the brain, the pleasure center that responds to chocolate consumption and nicotine consumption and sex and gambling. That whole area in the addictive cortex of the brain loves oxycodone, loves alprazolam, does not like even a little bit buprenorphine. But make no mistake about it, ladies and gentlemen, buprenorphine works as an analgesic. Therefore, you've got to retrain your patients and do drug rotation on your patients who are chronically consuming other medications and get them engaged with buprenorphine. So Buprenex was used 40 years ago. I told you, Al, Winnie, and I, and others were at the forefront of utilizing it to extend the duration of local anesthetic, regional anesthesia. Then about 12 years or so ago, transdermal patch came out. It's a 7-day patch, very useful patch. Addicts won't like it. Your patients who are treating their mood or chemically coping are not going to like buprenorphine. That's tough cookies for them. It's an analgesic. You can demonstrate using analgesic conversion tables how potent it is. And that reminds me to remind you to look up analgesic conversion tables, because you need to be able to calculate those morphine milligram equivalents. Those are available free of charge on the internet at multiple sites. Opiate or opioid conversion table. Download that, laminate it, put it in your office, tape it to the door, study it when your patients come in. And then, of course, Belbuca came in about 5 or 6 years ago. Again, all buprenorphine is indicated for moderate to severe pain. So we're talking about the numeric rating scale: 0, no pain; 1 to 3, mild pain; 4 to 7, moderate pain; 8 to 10, severe pain. We're talking about any pain between 4 out of 10 up to 10 out of 10 out of 10, whether it's at rest or with activity. Buprenex, Butrans, Belbuca, these drugs work. They're indicated as such. There's a low risk of physical dependency. Analgesic tolerance is very low compared to pure or full mu receptor agonists. What am I talking about? Compared to drugs like fentanyl or oxycodone or hydrocodone or hydromorphone, this drug is much less likely to lead to physical dependency and tolerance. And of course, it's a Schedule III drug. Learn your schedules. You don't want to be prescribing heroin or PCP, or for that matter, really probably not marijuana, because again, for federal law, which trumps state law, you can have some considerations and concerns on patients who are consuming marijuana. Learn that. Learn what your state regulatory agencies say about concomitant use of marijuana before you prescribe opiates to your patient. And Schedule III drugs, that would include buprenorphine, have a moderate or low physical dependence. Your true addicts will hate you for it. Those who are treating mood disturbances will hate you for it. Those who are treating pain may love you for the use of buprenorphine because it's a very good co-analgesic. Now, I told you we would talk a little bit about morbidities, about definitions. You need to understand psychiatric comorbidities because that can lead to a very high incidence of substance use disorder. Patients who've had prior DUIs, very high red flag patients. Patients who are addicted to nicotine consumption, very high red flags. Adults, males below the age of 45 who've had family disturbances, divorces, been incarcerated. You need to know what the red flags are in patients historically before initiating or perpetuating opioid use in your patients. Bipolar disorder, high incidence of prevalence of substance use disorder, especially with alcohol. Alcohol more than cocaine, more than marijuana. Cocaine dependence, however, pretty high, 20% incidence in lifetime in bipolar patients. Here's some data which suggests that the national incidence of depression is about 8%. The national incidence of any narcotic use is 6%. You take those two factors, however, depression and opioid use, and you accelerate, exponentially accelerate the two risks together. Opioids, which will accelerate the risk of depression, and depression, which will accelerate the risk of opioid use. How about adult ADHD with substance use disorder? Very high. 50% of adults who have ADHD will have a substance use disorder. How about personality disorders? Well, the antisocial personality, the person who's been incarcerated, those people have a very high incidence of substance use disorder, at least 60%, almost to the same extent that schizophrenics do, which again, and borderline personality patients, and anxiety and depression patients, and PTSD patients. Learn to recognize this. Learn this, to make this part of your regular assessment of patients. Have they had some type of traumatic event with PTSD? 52% of males will develop substance use disorder. Half as many women will develop substance use disorder if they've had a concomitant post-traumatic stress disorder, panic disorders. More than a quarter of them will end up with an alcohol dependency throughout their lives. So very important. Schizophrenics, I mentioned that almost 50% of schizophrenics are going to be abusing some type of substance. 80% of them are going to be nicotine dependent. Remember, nicotine dependent is an independent risk factor for substance use disorder, as is a prior history of DUIs, ladies and gentlemen. Learn to know the red flags. Adult male below the age of 45 with multiple family issues, multiple motor vehicle accidents. They've had divorces. They've had legal troubles. They've had bankruptcy. These are all red flags for substance use disorder. So how I'm going to summarize now what my recommendations are for those of you who are initiating, perpetuating, or establishing a prescription writing program for your patients with chronic non-malignant pain. Use the prescription drug monitoring program. Use urine drug toxicology. No opioids at the first visit. Now I'm going to tell you the tragic story about a gentleman, Todd Graham from Indiana, who followed this dictum step by step and still had a tragic outcome. No opioids first visit, no benzos. Remember, alprazolam is as addicting as heroin. If your patient is a codependent patient or has a dual diagnosis, ask them to make a determination what they want to treat more vigorously, their anxiety and depression using benzos or their pain. I give my patients the option. If your anxiety and your depression is what's destroying your life, then let's continue treating that. If it's your pain, then let's treat that, but we're not treating both. We're not going to mix benzos with opioids. Use an expectation of care agreement. There are many different terms for this, so that you have an out strategy if your patient is in violation of their agreement. Have a zero tolerance policy for eliminating patients from your practice. Don't be the softy, Mr. or Miss Softy, who lets the patient go after 3 failed drug tests. That will come back and bite you in a big way that you're not going to be happy about. Discharge them from your life. Get them out of your practice. Use 90 morphine milligram equivalents as a goal. If you go above it with legacy patients, you inherited it because your partner retired after 60 years and he was heavy on the pedal with opioids. Be careful. Ask about withdrawal. Remember, withdrawal from opioids is not life-threatening. Only withdrawal from benzodiazepines, barbiturates, and alcohol. Those 3 chemicals will kill your patient, but not opioids. In fact, as relates about alcohol, ask your patients about alcohol. Make sure you educate the patient about not sharing their medication, not using their neighbors or their child's or their parents' medication. Get the patient to psychotherapy who needs psychotherapy. Draw the line. Avoid methadone. Get a MAT, 8 hours of training to treat addiction. Learn about Suboxone and all the other things that you can use. Subutex for patients with addictive disorders. Join ASAM. Become a member of the American Society of Addiction Medicine. Read their literature. Todd Graham was a family medicine doctor out in South Bend, Indiana, near Notre Dame University. He was treating patients very effectively, very carefully with opioids, had a new referral. Middle-aged woman came into the clinic with her husband, demanding opioids for a chronic non-malignant condition. And Dr. Graham went to the physician drug monitoring program and checked them out. And he did a full physical exam and he checked the records from the prior doctor and said, well, you know, ma'am, I'd like to help you, but this is your first visit. And my policy here is I don't give opioids on the first visit. Well, the husband became irate. How dare you not treat my wife? She's going to have a withdrawal. And Dr. Graham said, well, I'm sorry about that. She can go to the emergency department if she's uncomfortable. We'll give her some other types of alternative strategy medications here, but we're not giving her narcotics. The husband was furious and he went out to the parking lot, waited for Dr. Graham. When Dr. Graham left work at the end of the day, the husband approached him. They had an argument, shot Dr. Graham twice in the head, and then turned his gun on himself and killed himself. Physicians, protect yourselves. Use the guidelines, but also recognize hot and volatile situations and call law enforcement. And when you have hot and volatile situations, have an exit strategy. Someone fails a drug test, they're eliminated. Consider if they have side effects and they're demanding a certain type of molecule, offer them an intrathecal drug delivery system. Rotate them off of their oxycodone to buprenorphine. Use opioid rotation. Do not use benzos. Consider opioid-induced hyperalgesia for those patients who have ongoing pain, despite everything that you are doing for them. And of course, read this great book, beautiful book, Controlled Substance Management in Chronic Pain. by Peter Statz, Sanford Silverman, great friends of mine. This will help save your career, help save your practice, and just as importantly, will help to save your patients' lives. Dr. Kenneth Candido from Chicago, signing off. Thanks, Dr. Waldman. Thanks, Kathy Waldman. And thank all of you from the Society for Pain Practice Management for listening to me today. Contact me if you have any questions, comments, or concern. And I appreciate all of you, and I'm privileged to have been here today. Have a wonderful afternoon, and thank you.